Hi, I am Ajit Virkud, Professor of Obstetrics and Gynecology from Mumbai.
Hello, citizens of the internet. In this part 2 of my talk on DUB, I am going to discuss the diagnosis and management of DUB. I am also going to elaborate graphically a hypothesis that explains how hormonal levels affect the stability or breakdown of endometrium. Diagnosis of DUB entails detailed history, general examination to look for features of anemia like pallor, tachycardia, or koilonychia. One must examine the thyroid for goiter. Per speculum examination must be done to rule out local causes like polyp, growth on the cervix, etc. Bimanual and rectal examination must also be done to look for any other palpable pelvic pathology. Suspect dysfunctional uterine bleeding when a patient presents with unpredictable or episodes of heavy or light bleeding despite a normal pelvic examination. Investigations which must be done for patients suspected to have dysfunctional uterine bleeding include complete blood count, pap smear, endometrial sampling, beta HCG, thyroid functions and prolactin assay, liver function tests, coagulation studies, etc. Pelvic ultrasonography must be done to rule out local organic pathology. Hysteroscopy or sometimes saline infusion sonography are other alternative diagnostic procedures. If and when surgery is planned, preoperative investigations may be required to be done. I will discuss the treatment under the following subheadings: general measures to improve health, medical treatment which may be non-hormonal or hormonal, and surgical treatment. The choice of treatment depends on the age of the patient, whether fertility is desired or not, and other comorbid factors. The primary line of treatment of any DUB patient is explanation and reassurance. The fact that there is no sinister underlying cause of their menorrhagia will give them a sense of relief. Maintenance of a simple menstrual calendar will reassure the woman. Improving health by lifestyle modifications such as advising adolescents to take to swimming, outdoor sports will help resolve the puberty menorrhagia. Obese patients should be advised to reduce weight. All women with menorrhagia have anemia, which must be treated with iron and folic acid supplements. Some patients with severe anemia scheduled for surgical treatment may require preoperative blood transfusion. Pubertal age group AUB should be treated with general measures. First, I will discuss the treatment of acute, emergent, uncontrolled abnormal uterine bleeding. Such patients require inpatient management to make them hemodynamically stable with intravenous fluids and/or blood transfusion. Bleeding is controlled with conjugated estrogens, Premarin, 25 mg given intravenously 4-hourly until bleeding stops for 12 to 24 hours. Usually 3 doses are sufficient. This is followed by oral conjugated estrogen 1.25 mg or 2.5 mg plus medroxyprogesterone acetate 10 mg daily for 12 days per month. If there is no response to high dose estrogens in 24 hours, then a dilatation and curettage or hysteroscopy may be required. Now I will talk about management of chronic DUB, which is more commonly encountered. All patients of chronic DUB should be offered medical treatment as the first line of management. It involves use of non-hormonal or hormonal drugs. As per RCOG 2002 guidelines, mefenamic acid, a prostaglandin synthetase inhibitor, 500 mg 3 times a day starting from the first day of the period should be the preferred first-line therapy for treatment of AUB. The treatment is especially effective in reducing blood loss in women who ovulate. It produces a reduction of menstrual blood loss by around 24%. Anti-fibrinolytic agents like tranexamic acid are an alternative first-line therapy for treatment of DUB in adolescent and reproductive age group. Given in doses of 1 to 2 grams 4 times a day for the first 3 to 4 days of the menstrual cycle, they reduce menstrual blood loss by about 50%. Tranexamic acid is also effective in treating menorrhagia associated with IUCD. Ethamsylate in doses of 500 mg 4 times a day starting 5 days before anticipated onset of the menstrual cycle and continued for 10 days is another non-hormonal treatment. The drug acts by maintaining capillary integrity. It has anti-hyaluronidase activity and inhibitory effect on prostaglandins. Ethamsylate in the currently recommended doses is not an effective treatment of menorrhagia. Hence, it is often combined with other treatments such as mefenamic acid. Before I talk about the hormonal treatment of DUB, one needs to understand the hypothesis that explains how hormonal levels affect the stability or breakdown of endometrium. This is not explained properly anywhere in the standard textbooks or on the internet, but is very important for understanding how to prescribe hormones in gynecology. The basis of this hypothesis is that there is an endogenous hormonal level, which is actually a range, the exact value of which is not known in a given woman, at which endometrium breaks down and is shed. When the endogenous hormonal levels are above or below this threshold range, the endometrium is stable and therefore does not bleed. This graph illustrates the hypothesis. When the hormonal levels in the body are below the threshold as shown in yellow shaded areas A and E, this is called subthreshold amenorrhea. When the hormone levels reach and remain in the threshold range as shown in the shaded area B, there is threshold bleeding. When the hormonal levels are above the threshold range as shown in the pink shaded area, there is superthreshold amenorrhea. When the hormonal levels come down from the superthreshold levels, as happens when you abruptly stop the high doses of progesterone in the DUB treatment and reach the threshold level, there is a hormonal withdrawal bleeding, shaded area D. The only type of bleeding that cannot be explained by this hypothesis is breakthrough bleeding. Here, what happens is that the hormone levels are in the super or subthreshold range and thus the endometrium is stable. But the threshold levels of certain small areas of the endometrium temporarily change to the current hormonal level and therefore it is said to break through and bleed. The objective of hormonal treatment is to promote universal, synchronous endometrial bleeding, structural stability, and vasomotor rhythmicity. Synthetic progesterones, that is Progestins, given cyclically are generally preferred as first line of treatment of chronic anovulatory DUB in women of perimenopausal age group after ruling out endometrial carcinoma. Premenstrual spotting is also treated by this regimen. 19 nortestosterone derivatives like northestrone acetate, medroxyprogesterone acetate, and natural progestogens like dydrogesterone used in luteal phase are preferred. Northestrone is given in doses of 10 mg daily from the 16th to the 25th day of the cycle for 6 to 9 months. In patients with endometrial hyperplasia, they can be given cyclically from day 5 to day 25 for 6 to 9 months. Given cyclically for 12 days per month, micronized progesterone 200 mg per day is also effective. Progestins in superthreshold doses can also be used for treatment of acute, emergent, uncontrolled dysfunctional uterine bleeding. When the progestin dose exceeds threshold levels, endometrium becomes stable and bleeding stops. Dose of 5 mg of northisterone acetate 4 to 6 times daily is started. The dose is increased till the bleeding stops, and the same high dose is continued for 2 more days. Usually it takes about 5 to 7 days for the high dose treatment to control the bleeding episode. After the bleeding is controlled, a maintenance dose of 10 mg per day is given for 2 more weeks, and after this 3-week treatment, the progestin is stopped abruptly, after which a hormonal withdrawal bleeding occurs. After this, cyclical progestin therapy in the luteal phase may be given for 6 to 9 months. For treatment of ovulatory DUB, combined oral contraceptive pills, that is estrogen plus progesterone, are used. They are given up to 4 to 6 times a day, that is suprathreshold dose, until the bleeding stops and for 2 days thereafter. Then a maintenance dose of 1 tablet daily is given for 2 weeks. When the pills are stopped, withdrawal bleeding occurs. This is followed by 1 tablet daily for 21 days, given cyclically for 3 to 6 months. Contraceptive pills have an efficacy of 39%. They also regularize cycles and provide effective contraception besides other miscellaneous benefits. Conjugated equine estrogens are used for treatment of acute, emergent, uncontrolled dysfunctional uterine bleeding. When given in suprathreshold doses, they will stabilize the endometrium and arrest bleeding. They stimulate clotting at capillary level and promote vasoconstriction of spiral vessels. They are given in doses of 25 mg intravenously 4-hourly until bleeding stops, or for 12 to 24 hours, followed by 1.25 mg or 2.5 mg plus medroxyprogesterone acetate 10 mg orally daily for 12 days per month. GnRH analogs can also be used for treatment of DUB. They act by down-regulating the pituitary. Decapeptyl or luprolide, that is Luprodex 3.75 mg injection by subcutaneous or intramuscular route every month for 3 to 6 months is effective. Treatment is limited to 6 months because of the risk of osteoporosis. Estrogen add-back supplementation can be used to prevent osteoporosis. They are used in women awaiting natural menopause or surgery, and young patients with medical disorders, anemia or immunosuppression. Ormeloxifene, a weak estrogenic and anti-estrogenic selective estrogen receptor modulator, has also been used in treatment of DUB. It is given orally in the dose of 60 mg twice weekly for 12 weeks and thereafter 60 mg once a week. 60% efficacy has been observed. It is preferred in perimenopausal DUB women with hormone deficiency. Danazol in subtherapeutic dose of 200 to 400 mg daily can also be used. It reduces menstrual blood loss by average 60%. Menopausal side effects and cost limit it to a second choice therapy or short-term use only. It causes atrophy of endometrium by competitive inhibition at receptor sites because of central action. It also has a carryover effect. Clomiphene citrate in the dose of 50 to 150 mg per day from day 2 to 6 of the cycle can be given for 3 to 6 months in patients with anovulatory DUB who desire pregnancy. Levonorgestrel releasing intrauterine system such as Mirena can also be used in the treatment of DUB. By releasing 20 micrograms of levonorgestrel, it produces marked reduction in blood loss, that is 80 to 97%. 20% may also have amenorrhea at 1 year. The LNG intrauterine system has been shown to be substantially superior to other medical treatments, including non-steroidal anti-inflammatory drugs and tranexamic acid. This option could also replace the need for surgery. That is, it may be an alternative to hysterectomy in many women. Other medicated intrauterine devices that are being investigated for treatment of DUB are Metraplant, which is a T-shaped intrauterine device with levonorgestrel on the shoulder and stem, and LNG-IUD, which is a copper T with levonorgestrel on the stem. Global endometrial ablation is a minimally invasive surgical option for heavy menstrual bleeding. It may be considered in women who have failed medical treatment, have completed childbearing, or who may not be candidates for major surgery. Endometrial ablation can be done by different hysteroscopic and non-hysteroscopic techniques such as transcervical resection of endometrium, thermal balloon therapy, thermochoice, microwave endometrial ablation, heated free fluid, that is hydrothermal ablation, cryoablation, and radiofrequency ablation. Non-hysteroscopic ablation techniques should be the methods of choice in view of their higher efficacy and safety than hysteroscopic techniques. When compared with progestin intrauterine system, ablation appears to have similar efficacy for bleeding control in women with abnormal uterine bleeding and an otherwise normal uterine cavity. While an overall patient satisfaction rate of greater than 90% is reported for most types of endometrial ablation, up to 30% of women will require hysterectomy within 4 years. It should be noted that endometrial ablation is not acceptable as a primary therapy because the procedure can hamper the later use of other common methods for monitoring the endometrium. The last but not the least option for DUB treatment is hysterectomy. Hysterectomy offers women with DUB a definitive solution and is known to have high rates of patient satisfaction. Indications for hysterectomy are perimenopausal age group patient who has finished childbearing, endometrial hyperplasia with atypia, medical treatment has failed, cannot be tolerated or is contraindicated, other pelvic pathology that needs treatment, and failed endometrial ablation. If hysterectomy is required, the least invasive method should be offered to minimize morbidity and recovery time. The routes of hysterectomy in order of preference are vaginal hysterectomy, laparoscopic hysterectomy, and lastly abdominal hysterectomy. Although total hysterectomy is done usually, subtotal, that is supracervical hysterectomy, may be done. It should be noted that the rate and degree of cellular proliferation or its inhibition are greatly influenced by a group of local growth factors. These growth factors may play an important role in regeneration of endometrium. Pathophysiological role of the following endometrial growth factors needs to be researched: epidermal growth factor, insulin-like growth factor, platelet-derived growth factor, and transforming growth factors alpha and beta. Development of growth factor analogs may provide a new therapeutic tool in DUB treatment. This is the end of my e-lecture on dysfunctional uterine bleeding. For further reading on this topic and other topics in obstetrics and gynecology, refer to following books written by me. Practical Obstetrics and Gynecology, Modern Obstetrics, Modern Gynecology, Clinical Cases in Obstetrics, Questions and Answers, Clinical Cases in Gynecology, Questions and Answers, and Pelvic Reconstructive Surgery. If you have found this video useful and informative, please subscribe to my YouTube channel by clicking here.